Well, it's such a pleasure to see you all here. I know that with majority of you, I probably have been spoken on the phone, but we haven't really met in person, so it's wonderful to have a chance to actually put the face to the voice, so to speak. So my presentation is going to be about decision-making in advanced illness, and you see my name, I'm Marianna Diloyan, and my colleague, Mary Ersic, who will take care of the second part of the presentation. So moving forward, for the next 15 minutes, I'm going to be talking about certain objectives with you. And I'll be discussing some non-medical treatments for common FTD symptoms. We'll also be talking about those symptoms. We'll discuss them more in detail. Can you hear me better? Okay. Good. So as I mentioned before, we'll be talking about some treatments as well as symptoms, and we'll be talking more about in detail about the symptoms. And Dr. Mary Ersic will be talking about making treatment decision-making in advanced illness. So I know Dr. Grossman has covered some of the general features of FTD, and we will go over this again. Briefly. So for this presentation, I would like to concentrate on two clinical syndromes of FTD. So this would be behavioral variant of FTD, and in this condition, patients primarily develop behavioral issues. So you would see them develop apathy, they can lose empathy, they can become socially inappropriate, as has been mentioned prior. And patients can also develop something called primary progressive aphasia, which are difficulties with speech and language comprehension. And for the FTD in general, we'll be talking about management of the symptoms in 4 domains of intervention. So these domains would be behavioral symptoms and challenges. We'll be talking more about this in detail in terms of how to manage those challenges. We'll be talking about executive difficulties, which is a problem with planning and organizing. We'll be discussing some issues with speech and language comprehension. So what I mean by this is that patients primarily have divided in 2 divisions in terms of difficulty with speech, such as patients with a non-fluent variant PPA. So these are the people whose speech is very effortful and slow, but the comprehension is still preserved. And we'll be also talking about patients who develop something that's called semantic dementia or semantic variant of PPA. So in these patients, the fluency is preserved, but they often speak out of context, and there's really no understanding of the word's meaning per se. But again, the fluency is still there. And we'll also be discussing the issues and challenges in regards to visual-spatial difficulties. They are more common in patients with corticobasal syndrome and progressive nuclear palsy. In non-pharmacologic interventions, those are non-drug-based behavioral or environmental strategies to be employed by caregivers to reduce severity of FTD symptoms. And of course, they can be used alone or in conjunction with medication therapies, but of course we want to concentrate more on a non-invasive approach first before we move forward to the invasive one. So let's talk more about the behavioral challenges, something that you can see in your loved one in terms of the changes in behavior. So you can see changes in the behavior such as aggression. So your loved one might be behaving more physically and verbally abusive. You might notice some cursing, some hitting, kicking, biting, etc. You might also notice some disinhibition. So there's some lack of restraint in social setting. As we mentioned before, people can just approach strangers on the street, start talking to them, approach little kids, want to pick them up, play with them. And again, there is really no any maliciousness involved, but there's just a lack of ability to inhibit that impulse. We also will be discussing the hyperorality. And this is just the impulse to consume large amounts of food. And a majority of your loved ones, you probably noticed that they're attracted to sweets, carbohydrates. And also, there can be a case when people eat something that is non-edible. Also, you might notice that there are some ritualistic behaviors. So there can be hand clapping, tapping, humming the same tune over and over again, eating certain amounts of food at certain time. And you might note some hypersexual behavior. So your loved one might be preoccupied with sexual jokes. They might touch someone inappropriately. So you might notice some of these changes in behavior in your loved ones. Also, there might be some emotional symptoms, such as apathy. So apathy is expressed as indifference, reduced initiative and lack of motivation. And as Dr. Grossman mentioned before, it does range in severity. In more of a severe stage, people can become apathetic enough as to not wanting to use the bathroom, even though they feel the urge to urinate. There is some lack of insight, which is very frustrating for our caregivers. So your loved one might not recognize that they have an issue. You might go to the physician's office and your loved one might say, well, I think everything is okay. I don't think that there's a problem. And it might be very frustrating for our caregivers. There might be also some emotional blunting, and there's lack of empathy, sympathy, again, laughing at things that should not be laughed at, and just lack of regard for people that they used to love and really care about. And there can be some mood changes. Those can be very abrupt. One moment the patient is very happy, and another moment your loved one can be just very aggressive, and it's normally without much of a provocation. So you might also notice some impairments in executive functioning. So there can be some difficulties in planning and organizing. So there's a difficulty in managing a checkbook, for example. You might notice that. You might notice that your loved one is distractible. So as you talk to him or her, they pay attention to everything else and being distracted by other stimuli, but not paying attention to you. And there's also going to be an issue in discourse, oftentimes. As we talk, we normally try to limit our speech to the topic that is currently being discussed. However, in patients with FTD, often they go on tangents, which are not related to what's discussed, and it can make for very frustrating conversations. So what are some of the interventions that we can use that are non-medical interventions, so to speak? So there's things that you can do to address those challenges. So first of all, it's important to determine when symptoms are likely to occur. Is it more in the morning, after your loved one wakes up? Is it more at lunchtime? Is it more around the dinner? Is it after you go to visit some concert and they're overstimulated by some excessive stimuli? What exactly is going on? What is truly triggering them to behave in a certain manner? Also determine what precipitates the symptoms. Again, the same thing. Try to see what exactly makes them behave in a certain way, what makes them more upset, or rather what makes them behave in a calmer manner. And plan interventions to reduce the precipitants. And we find that maintaining a behavior log is very helpful. If you keep writing down what you notice, you'll eventually be able to decipher what exactly is triggering the issues or when the symptoms are likely to occur. And you might find it very helpful. And therefore, as you know what exactly is triggering the symptoms, you can address those issues later on or prevent them. What's also important is to develop a regular schedule and a curriculum of activities like in a classroom. It really takes all this decision-making out of the picture for the patient, makes it easier for them, and it's going to be easier on you as a caregiver to have it planned. Also, try to divide activities into smaller components. It's also simpler. So, for example, instead of saying, help me to set up a table, just explain that you would like to have some help with, taking knives out and putting them on a table, then taking some forks out, putting them on a table, etc. Just try to divide the activities into smaller components that are easier to understand. Maintain a calm environment, so just try to reduce the amount of stimuli your loved one is experiencing. We find that it's sometimes very helpful in preventing any abrupt behavioral changes. Try to redirect softly if you see that your loved one is concentrating on something, like maybe attracted to a shiny object in the store. Try to redirect, try to stay, maybe step in between that object and your loved one and try to redirect the attention of your loved one. Consider day programs. Those are wonderful. Community centers, they already can have built-in curriculum for your loved one to participate, and it can keep your loved one busy, which is important. I would like to concentrate specifically on driving. It's just such an important issue, and we all know that driving is a very complex task. It does involve lots of stimuli. It does require rapid decision making, and in majority of our the group of our patients, driving is an issue. It's very complex. It does require processing of visual-spatial stimuli, and it might be difficult or almost impossible to accomplish for some patients with FTD. So don't be the bad guy. Make your physician be the bad guy. Make a physician make the judgment in terms of whether your loved one can actually continue to drive. So bring your loved one into the office and make your physician order the evaluation. Evaluation will be complete, and if driving should not be done, then there are several steps that you can take. You can explain to your loved one that you can't drive anymore, take driver's license away. It's going to be very frustrating because driving is kind of a symbol of independence, and no one wants to lose this independence, but it's important. It does involve lots of legal issues when patient who is unable to drive and process information is actually driving. It's not safe, neither for your loved one nor for people who can be on the way, so to speak. If your loved one continues to insist that he or she wants to drive, consider to either slowly winning driving. They might drive around the neighborhood, and then just slower and slower, they can drive through the lesser territory, and then eventually they would not be driving. And if they still persist on driving, then you can consider disabling the car or selling the car, getting rid of a car somehow. So temptation is not there, okay? But that's going to be a last resort. So let's talk a little bit about the speech and language difficulties. As I mentioned before, patients with semantic variant of PPA develop difficulties in comprehension. So they demonstrate word-finding difficulties, deficits in word comprehension, and impaired object knowledge. So you would notice that someone who used to love reading the books and newspapers are not reading those anymore because they can't understand what they are reading. In those with non-fluent PPA, speech is affected. So again, speech becomes very effortful, very slow, and it's important to give your loved one a time to express themselves. But in this case, the comprehension is normally preserved. It's primarily the motor aspect of speech that is affected. So what are some of the interventions to improve the comprehension? So there's things that you can do. Again, speak slowly. Give it a time for your loved one to process the information that you are trying to communicate. Again, with the same goal, just use shorter and simpler sentences. In our speech, we use very complex sentences with lots of nouns and adjectives. Try to simplify your speech. Speak redundantly. Don't be afraid of repeating yourself. In this case, it's really needed. It's going to help your loved one to understand you, or increase the chance that they will understand what you're trying to communicate. Try to speak in context. So if you're discussing dinner, don't speak in the bedroom. Take your loved one into the kitchen and talk about dinner there. It's going to be easier for him or her to understand what you're trying to communicate. Use gestures, again. Try to point at the objects that you are referring to. Use picture cards, the same purpose. If they can't recognize the word, your loved one can usually recognize the object, and they can point to the object and say, here, that's what I was referring to, cup of water. Consider speech therapy, and as the previous talkers mentioned, it's can be a wonderful resource. The speech therapist can certainly train your loved one to use the words that they normally are used in the day-to-day lives, like toilet, toothbrush, etc. It's going to make it easier both on you and your loved one to communicate if at least the comprehension of those basic words is preserved or maintained. So what are the things you can do to facilitate the speech? Again, give it a time. Yes, it can be very frustrating for some patients when they have difficulty just expressing what they want. So it's important to continue give them a time to express themselves. Eventually, if they become too frustrated, you can resort to written communication or computer-assisted devices. Those can be very helpful. But again, it's important to allow some time for patients to express themselves. Also, we often get asked, when is it appropriate to intervene, to help out? When patient is stuck in terms of expressing themselves, when can we intervene? And what we want to say is that, it's important for your loved one to use the language. So the more you use it, the better there's a chance it's going to be maintained. And at the same time, don't let him or her be too upset. It's going to be up to you when to intervene. So allow him or her to use the language, but if it becomes very frustrating, please do join in and try to help out as well. So let's touch base on some visual-spatial impairments that can be seen in your loved one. So spatial orientation difficulty is normally expressed as difficulty perceiving visual objects. So people normally don't notice objects, even if they are right under their nose, so to speak. They're right there, and your loved one might not be able to see that object. So again, difficulty locating objects in space, difficulty locating self in space, and therefore wandering, which is a safety issue. And apraxia, which is expressed as impairment use of implements. And by implements, I mean tools like knives, forks, different utensils, etc. So people with apraxia do not know how to use these objects that they were familiar with in the past. And difficulty with dressing, again, buttoning up shirts, dressing overall becomes a challenge. So what are the things you can do to address these challenges? So when it comes to the difficulty with spatial orientation, just try to mark problem areas. Using a bright tape is a great tool. So for example, stairs, it's a dangerous place to be at. It's really very important to make sure that your loved one is aware of where stairs are. So try to mark the stairs with the bright tape. It's also would be helpful to apply the tape along the banister as well. It can help your loved one to orient themselves better in the space. Remove the throw rugs and toys. Try to clear the environment. Try to reduce the amount of stimuli in the room. It's would allow your loved one to process information better. And again, driving. I talked about driving a little bit before, so with visual-spatial difficulties, driving can become pretty much impossible. So please refer to your physician for evaluation. Now, interventions to assist with apraxia or difficulty with using some utensils and tools would be to consider physical therapy, because physical therapy can be very helpful with any issues such as contractures, and just easing the way that people can use their limbs. It's very helpful in this case. And also occupational therapy. Occupational therapists can also order a home evaluation, and they can help you out in terms of how you can rearrange the environment to assist your loved one in managing it easier. And they can give you some tips on what you can do around your home to just prevent any falls, prevent any confusion of your loved one, make it easier for them to orient themselves. So now I would like to talk about the staging of the condition per se. So on this graph, hopefully I can make it point, you see that we have a relation with time and the ability to be independent. So as the time goes by, majority of patients, their ability to still be independent in their activities of daily living does go down. So in a mild stage, which is also the longest stage, majority of patients are still able to sustain some independency. So in this case, what you normally see would be the symptoms that normally brought you and the loved one into the physician's office. So you would notice some behavior changes, there might be speech issues, some speech hesitancy. Patients with semantic dementia, again, might have difficulties with word comprehension, etc. And this is the longest stage. So patients and your loved ones can normally stay in that stage for a long period of time. Now, as you progress in the condition and develop and enter the moderate stage, new symptoms might emerge. So, for example, if your loved one has been diagnosed with semantic variant of PPA, they can exhibit new symptoms like rigidity. And you normally see new symptoms such as incontinence, hallucination, confusion as your loved one can move into moderate stage. In a severe stage, now your loved one probably is completely dependent on you for all the activities of daily living. In this stage, we normally see people developing infections, UTI infections. So it's very important to watch for the infections. And overall, they're either bed or wheelchair bound. So the amount of care that you need to provide does differ drastically from the mild stage. But again, it's important to remember that the mild stage is the longest stage, and majority of patients stay in a milder stage for a longer period of time. Now, the prognosis, it does vary greatly from individual to individual. It's difficult to predict, how fast someone progresses, and I hear a lot of caregivers asking me, how fast they should anticipate. And we always advise to plan for long-term disposition, but truly there is really no way to predict for sure when things move from mild to moderate to severe stage. Overall, though, the duration ranges from 2 to 15 years, and on average, we notice that the condition lasts for about 86 months. But again, as you see that there is a very broad range, 2 to 15 years, it's quite a difference. So now I would like to invite my colleague, Dr. Mary Ursig, and she'll be talking to you about the making treatment decisions in advanced illness. Thank you.